everyone. Welcome. We are so glad you're here. My name's Jenny Dunn. I'm the Senior Director of Marketing at the Arthritis National Research Foundation. And on behalf of our entire team, I want to welcome you to Beneath the Surface. This is the first webinar of ANRF's Arthritis and Lupus Awareness Month series, and we are just so excited to kick things off with this conversation. We have a wonderful program ahead today, so I hope we're all excited. I want to just take a moment to thank our sponsors at Lilly for their generous support of this program. It's because of partnerships like this that we're able to bring important independent education directly to our community. So thank you so much. A couple of housekeeping items for you. This webinar is being recorded, so we'll have it available on our website and YouTube channel in the coming weeks. Feel free to share it with anyone who wasn't able to join us live today. If you have questions, we would love for you to type them into the Q&A box that you'll see below. We have dedicated time for a Q&A at the end of this program, and I'll be reading your questions to the panel, and you can get those questions answered. If we don't happen to get to yours, please do email us at info@curearthritis.org, and we will follow up with you there. We're going to be running a few short poll questions throughout the session. They're a great way for us to get to know you and personalize this conversation. So please do participate to see to help us with those when they pop up. Now, just a little bit about the program today. We know so many of you living with arthritis and lupus and autoimmune conditions have been hearing a lot lately about weight, metabolism, GLP-1 therapies. There's a ton of information out there and a lot of questions. And today we really hope to help you sort through all the noise. We have an incredible group joining us, and you'll first hear from a fellow community member who's navigating this firsthand. Then our expert faculty will walk us through the science in plain language, what we know, what we're still learning, and what it might mean for you and your care. Before we dive in, I would love to hear from you. So I'm going to launch our first poll, which is just the question of what brings you here today. Are you living with arthritis and autoimmune disease? Are you a caregiver? Are you a healthcare professional? What brought you in our doors, and how can we help you learn more? Okay, I'm seeing we have a lot of folks here living with arthritis and autoimmune disease. I'm going to end the poll and share these results with you so that you can take a look. I think we have a lot here to help today, and it's really helpful to know what brought you in our doors. To get us started today, I am so thrilled to introduce our patient advocate, Staci Stringer Betschart, who is not only an incredible, passionate advocate living with rheumatoid arthritis and psoriatic arthritis, but also a very valued member of our board of directors. Her perspective and her voice are central to much of what we do here, and we're so grateful that she's here today. Staci, the floor is yours.
Thank you, Jenny. So I know a lot of people probably have heard a little bit about my story, but my new journey with the GLP-1 has always been something that I became so excited about when it was an option. So I was diagnosed with rheumatoid and psoriatic arthritis when I was 17 years old. I was trying to get a college volleyball scholarship to play volleyball after high school, and I was a very competitive athlete. I had a part-time job at a coffee shop, and I kept dropping my milk on myself, and I didn't know what was wrong. So I was sent to go as a teenager. They thought I had carpal tunnel. So I did a bunch of carpal tunnel testing, and I progressively got worse and worse and worse. And part of not knowing what was wrong with me, doctors just put me on prednisone to deal with my pain. And I was on such a high dose of prednisone that I gained over 100 pounds in the first 6 months of me trying to find a diagnosis. And that weight has never come off. As an athlete and someone living with arthritis, when you're very competitive, especially with yourself, when you have a good day and you're feeling well and you try to go be active and work out, you push yourself and you almost push yourself too hard. And it's always, still to this day, is hard for me just to do light walking or something that's just slowly active, because I'm so used to getting a great workout in and pushing myself. And it becomes this cycle of then I flare and I'm in pain. And so it's been a huge challenge my whole life to try to find an easy balance. And when I first heard about GLP-1s, I had a very negative perspective of them. They scared me. I didn't want to take something that was going to, I'd have to be on my whole life. Granted, I'm on arthritis medications that I'll be on my whole life. Hopefully not. Anyway, I had a couple friends, one that was a dietitian that kind of changed my perspective on it and told me about all the health benefits that come from it, as well as how it can help the inflammation in my body. So, after talking to another friend who actually had started it and she has lupus and arthritis, it kind of gave me that little push to what am I waiting for? I need to change now. I need to make an effort to lose some of the weight, get some of these cravings down because I can't always be incredibly active. It does hurt my joints right now, and hopefully I can get to that point where I can. I've always been told motion is lotion. So I've been very happy with where things are going right now. It's definitely changed my life. I'm still in the beginning of my journey, but I'm very excited about it. I have felt a lot of improvement already, and just my energy level has increased. And I'm excited to see what is next for me.
Thank you so much, Stacy. I think so many people here can really hear themselves in your story, and that's exactly why we wanted to open with your perspective. We're so grateful to have you here. We're going to be hearing more from Stacy later in our Q&A. So again, if there are questions coming to mind, please do add them there. We'd love to get those answered for you. Um, I am so honored to introduce our first presenter, Dr. Helena Jonsson. Dr. Jonsson is a rheumatologist, a physician scientist, and an assistant professor at the University of Colorado Anschutz Medical Campus. Her research dives deep into the immune system, uncovering how specific cells contribute to autoimmune diseases like rheumatoid arthritis. She's published over 40 scientific articles and is a nationally recognized educator and mentor. And of course, she's a former ANRF scholar, which makes us especially proud to have her here with us today. Dr. Jonsson, thank you so much for being with us.
All right, thank you so much. I'm very happy to be here. I prepared just a few slides to kind of introduce a little bit of the science and the clinical studies behind weight and rheumatoid arthritis, psoriatic arthritis, and lupus. And I'm going to go through them relatively quickly because I want to leave a lot of time for that Q&A at the end. Um, and so, oops, going a little too fast there. So there are two kinds of connections between weight and rheumatologic diseases. I'm going to use the term rheumatologic diseases to refer to psoriatic arthritis, rheumatoid arthritis, lupus, and also other autoimmune diseases. If you have something other than those three things, this applies there as well. So obesity and fat cells in the body can have direct effects on the rheumatologic disease. And I think this is something that Dr. Faust will be telling us about a little bit later in this session. There are increased inflammatory factors, cytokines, and other things that can sort of drive the inflammation of the arthritis or of the lupus. There's increased mechanical trauma to the joints from the increased weight, and that trauma can in turn fuel, more of the fire of that inflammation. And then the other thing is that, a lot of our medications are sort of dosed as like one adult dose. If you take adalimumab or Humira, for example, it's one dose every other week. And it doesn't matter if you're teeny tiny or if you, are like 6'5", or if you are struggling with some weight issues, everyone gets the same dose. And that means that people who are larger get a lower dose per pound. And so that can also lead to effects. The other thing that I haven't included on my slides, but I'm happy to answer questions about later, is that obesity can affect some of the complications of rheumatologic disease. So a lot of people who take prednisone, for example, over time they might develop type 2 diabetes, for example. Weight contributes to that and increases the risk even further. High blood pressure and heart disease. Heart disease is a known complication of rheumatoid arthritis, for example. So if you have rheumatoid arthritis, that increases your risk. If you also have weight issues, that is a different additive increase to your risk and pushes it even higher. And then, of course, as we just heard from Staci, it's harder to maintain physical strength and fitness if you're in pain. And so it's harder to do those things that your primary care doctor might have been mentioning to you that you should do. So how do scientists measure weight? Like we don't usually talk about pounds because again, so I'm 5'2". Like my weight compared to like an NFL player's weight, it's like talking about pounds is like not super useful. Instead, we use something called body mass index or BMI. You probably have heard of BMI, but you might not know exactly how it's calculated. This is the equation here, and you're probably looking at it saying like, what does that even mean? So the equation is that you take your weight in kilograms, so not pounds, but kilograms, and then you divide it by your height squared. So for me, it would be my height in meters, which is roughly 1.6 times 1.6. And if you're thinking like, I really didn't think I'd need a calculator for this talk, that is true. I put this table here on this next slide. And so hopefully, this might be hard if you're using a phone, but hopefully if you're using a laptop or other computer, you can sort of look at your weight in pounds here along the top, your height in inches along the side, and sort of find out like where you are. Are you in the green zone? That means you're at your target weight. If you're in the yellow zone, that means you're overweight. If you're in the orange zone, that's an obese range. So that tends to be about BMI of about 30 to 40. And then severe obesity is a BMI over 40. And so here you can see, like this helps us take height into account. BMI is not perfect. There are lots of issues. Most NFL players would be considered either obese or in some cases severely obese, even though they're incredibly physically fit. And so this is not the be all and end all of physical health. It's just sort of the best weight measure that we have. And so this is what you're going to see the studies circle around. All right, so psoriatic arthritis. I'm going to be talking today mainly about psoriatic arthritis, rheumatoid arthritis, and lupus. For psoriatic arthritis, obesity is a well-known risk factor, well-known. And I wanted to get you some like statistics on this. And so this study here, published in 2012, looked at a study. It's called the National Nurses Study. It was 89,000 nurses who filled out surveys every year for like 20 or 30 years and reporting like what they ate, how much they weighed, new medical diagnoses, all these different things. And what they found in that big nurses study is that people who had a BMI over 30, so in this table that we just looked at, people who had a BMI in this orange range here, between 30 and or above, they had a threefold increased risk of having psoriatic arthritis compared to someone with a normal BMI. If you had a BMI over 35, so sort of on the more obese side, you had a six-fold increased risk of having psoriatic arthritis. So more weight means a gigantically larger risk of having psoriatic arthritis. We don't really understand why there's such a strong link between weight and psoriatic arthritis. I think that's something that we're starting to learn more about, but we definitely need more research about. As I was looking around, I saw this study, like that shows that weight loss, just weight loss alone, without any change in psoriatic arthritis treatment, can actually help reduce disease activity. So this was a study in Sweden where, I mean, like you probably do not want to do this. So what they did is they took people and for 6 months, those people ate an extremely low calorie diet. People lost between 16 and like 100 pounds on this diet. Like this was an extreme diet. But they wanted to see if like an extremely conservative diet and weight loss would lead to improved disease scores in people with psoriatic arthritis. And these are two graphs from that paper. The one on the left, the one that's green, shows a skin disease measure. So it measures how much of your body surface area is covered by psoriasis, because again, this is psoriatic arthritis. On the right is the arthritis score. So how severe is the joint disease of your psoriatic arthritis? Baseline is before people started this diet. And then you see the 3 month and the 6 month data points. And you can see that the bars for the, especially in the green, go down for 3 months and 6 months. So weight loss led to a pretty big improvement in skin disease and a similar improvement in joint disease. And so it looks like weight and inflammation are pretty intimately connected in psoriatic arthritis. For rheumatoid arthritis, obesity is also a risk factor, but a milder one. So again, in the same nurses study, and they actually combined two different nurses studies. So this is over 200,000 nurses. They found that having a BMI over 30 led to twice the level of risk of getting rheumatoid arthritis. So heavier people did have an increased risk of rheumatoid arthritis, but only twofold. It wasn't that threefold or sixfold risk that we just heard about for psoriatic arthritis. Um, the risk for RA, the risk for developing RA is like relatively modest. But another thing to think about is again, this, like how do you respond to treatment? And so in this graph here, this is showing disease improvement over time. So the y-axis is the percent of patients with rheumatoid arthritis who are in remission, who have a very low disease activity score. And on the x-axis, we see over time. So 8 weeks, 12 weeks, 24 weeks, and 48 weeks. So this is over the course of a year. For people who have a BMI less than 30, that's the blue line. So you can see when they start their treatment, within the first 8 weeks, about 60% of them reach a low disease activity state, which is great. And then over a course of 6 months to the 24-week point, it's about 80%. But for people with a BMI over 30, that's in the yellow line, only about 45% of patients had low disease activity at 8 weeks, and then it plateaued at about 50 or 60%. So you're less likely to get to a low disease state if you are obese. For lupus, it's actually the other way around. And I think that the reasons here are completely different. So for lupus, it actually turns out that having low body weight, so a BMI that's like 18, 20 being underweight, is actually associated with more severe lupus. And that is seen, that was first reported in the study here at the top. And then here we have a graph. So we have body mass index on the x-axis and then lupus disease activity on the y-axis. And you can see that people with low body mass index, so the ones that are closest to the left side of the axis that weigh less, they have a higher lupus disease activity. And the people with lupus who have a higher BMI on the right side have lower disease activity. This is probably not because, this is probably because people with lupus who have severe lupus actually have a hard time gaining weight. They're very sick, in the same way that like cancer patients are sick, and therefore it's hard for them to maintain body mass. And so this is probably a totally different phenomenon than what we were seeing in rheumatoid arthritis and psoriatic arthritis, and we can talk more about that later. So I think everyone is wondering, okay, like there was that study in Sweden where they put everyone on a super calorie restricted diet. Um, that was before GLP-1 agonists. How do GLP-1 agonists work for rheumatoid arthritis and psoriatic arthritis? Do they help with these diseases? Is it just the weight loss that's helpful, or is it other molecular things that are happening? And is anyone even studying this? This comes up in my clinic, at least like about once a week now. And so GLP-1 agonist, that's the sort of umbrella term for all these different medications that you probably have heard about. So Ozempic and Mounjaro and Wegovy, most of them are injections. Just in the last year or so, they now are also available as pills. And so I've put pictures on here so you can kind of see the different names that we're talking about here. Tirzepatide and semaglutide are the generic names for the two primary ones that people are taking. So tirzepatide and semaglutide. All of these medications mimic a substance that your body makes naturally called GLP-1. GLP-1 is made by cells in the gut in response to what you eat, and it essentially acts like a natural appetite suppressant. This molecule GLP-1 binds to a receptor called GLP-1 receptor, and the medications do the same thing. The medications stimulate the GLP-1 receptors and have some of these same effects. These medications were designed for weight loss, and they lead to weight loss through several different mechanisms that I've illustrated here. And I've taken this image from a review article from last year that I found very helpful. So first of all, it makes your body more sensitive to insulin, and that's good, because like type 2 diabetes, for example, is a disease where you're not very sensitive to insulin. That's bad. So diabetes is low insulin sensitivity. GLP-1 agonists naturally improve insulin sensitivity, and it also slows the traffic of food through your gut, both through your stomach and through your intestine. That helps you feel full longer because the food remains in your belly longer. And so you sort of get that full feeling lasting for a longer period of time. GLP-1 agonists also act in the brain on the appetite sort of focus in your brain, where it reduces appetite and helps you feel fuller for longer. And so by acting both in the gut and in the brain, GLP-1s help people eat less and thereby lose weight. So, and I think let's see here. Oh, all right. And so again, GLP-1s lead to reduced hunger, reduced food intake, and weight loss through that mechanism. These medications are also approved to treat type 2 diabetes. And that's because one, it makes you more sensitive to insulin. And that's helpful in diabetes. GLP-1s also act on the pancreas and have all these different effects that I'm not going to go into detail about here, but it helps with type 2 diabetes. Great. GLP-1s also act on a whole bunch of other parts of your body, most of the time doing helpful things, sometimes doing maybe less helpful things. We're still figuring the rest of this out. And so I think as a rheumatologist, that's one of my questions is, are GLP-1s helpful across the board? Are they maybe less helpful or even harmful for certain things like bone health? Like what do we need to keep an eye on for our people with arthritis? And, so I spend most of my time doing research, and I think a lot about these cells. So these are the cells in the immune system that participate in attacking your joints in rheumatoid arthritis and psoriatic arthritis. Many of these cells express the GLP-1 receptor. They will be seeing signaling from these GLP-1 agonist medications, and we don't yet know like how the cells are affected by that. These are things that people are starting to study now, but these medications are so new that we don't fully understand. There is one clinical trial, and this came out literally just a couple of months ago, where they compared in psoriatic arthritis taking ixekizumab, that's the medication that goes under the brand name Taltz, either using ixekizumab alone or alongside tirzepatide, one of these GLP-1 agonists. And so to see like whether the combination of the two medications worked better for psoriatic arthritis than just the Taltz, the psoriatic arthritis medication alone. And so again, here, ixekizumab, that goes under the brand name Taltz. Tirzepatide, that's the one that goes under the brand name Zepbound and Mounjaro. But again, ixekizumab works in the same way as Cosentyx. Tirzepatide works very similarly to Ozempic and the other GLP-1 agonists. So I think we can take this clinical trial and sort of start to understand what these different medications do in a more general sense. Okay, so it's perhaps not surprising to see that the people who were taking the tirzepatide, the Zepbound or Mounjaro, lost more weight. So this is the percentage of people who lost at least 10% of their body weight. And so if you weigh 150 pounds, this means that you lost 15 pounds. If you weigh 200 pounds, this means that you lost 20 pounds during the course of the trial. And it turns out that 80% of the participants who took tirzepatide lost weight. Only about, maybe 5 or so percent of people taking just the Taltz, just the ixekizumab, lost that amount of weight. But what I really want to know is, what happens with joint disease, right? Did this help more with joint disease if you took both medications together compared to only one? And the answer is yes. It was a little bit better response. So over here, the white bar is showing the percentage of people who had a 50% improvement in their sore joints on ixekizumab alone. And so that turns out to be about 20% of people felt 50% better on Taltz alone. If people took Taltz and, the Zepbound or Mounjaro together, the ixekizumab and the tirzepatide, 33% felt 50% better. So that, it's not a gigantic amount, but it is better to take both than just the Taltz. And so what I think we're seeing happening here is that we're going to be seeing more trials like this, and I wouldn't be surprised if these companies that make these GLP-1 agonists will start to pursue FDA approval for this indication. All right, and happy to take questions about GLP-1s and all of that in a few minutes.
Yeah, Dr. Jonsson, thank you so much. That was incredibly clear, very helpful. I know our audience appreciates you taking such complex science and making it so accessible. So again, we'll hear from Dr. Jonsson later in our talk today. Please do keep putting your questions into the Q&A. At that, I have another quick poll for you. I would love to hear. How confident do you feel talking to your doctor about this topic? Do you feel really confident you know just what to say? Do you feel somewhat confident? Are you already having these conversations? We'll check this one again at the end. I know that a lot of people are starting to have these conversations with their doctor, and it looks like we're kind of in the middle to not knowing quite what to say. I'll share these results with you so you can see what you've all said. Thank you so much for sharing that with us. We'll come back to this one later to see if maybe we've gotten a little more confident over time. Next, I am so pleased to introduce our next presenter, Heather Faust. Dr. Faust is a former ANRF scholar as well. She received her PhD from the Johns Hopkins School of Medicine in the Cellular Molecular Medicine program, and she was most recently a postdoctoral fellow at Brigham and Women's Hospital. The cutting edge work she's done in immunometabolism is exactly what this conversation is about. Funny enough, as just an anecdote, when we were asking around about what researcher might be a good one to join us for this, everyone said Dr. Heather Faust. So I'm so thrilled she's here. Dr. Faust, thank you for joining us. I'm going to hand it over to you.
Thank you, Jenny. It's a pleasure to be here. I'm also excited because Dr. Helena Jonsson and I worked together for several years at Brigham. So it's a pleasure to see her on the webinar and see her insights into this problem as well. So my side of the talk is going to be more on the research side of immune metabolic interactions, although I'm sure Helena is also very well equipped to do this side as she has amazing research as well in this area. So this is just a fun fact. I did this drawing actually in high school and was interested in medical illustration before I decided I was actually more suited to research. But this is a charcoal drawing of a knee joint. Little did I know that I would be spending a lot of time thinking about knee joints in my future. Okay, so I am going to be focusing on arthritis, but I wanted to mention that there are many autoimmune diseases associated with obesity. Besides rheumatoid and psoriatic arthritis, as Dr. Jonsson mentioned, also psoriasis, which affects your skin, multiple sclerosis, which affects your central nervous system, Hashimoto thyroiditis, type 1 diabetes. And these are all autoimmune diseases that have clinical data showing that obesity increases the odds ratio, the likelihood of developing these diseases. Other diseases that are associated not purely with obesity, but somewhat with metabolic syndrome would include lupus, as Dr. Jonsson mentioned. There are metabolic issues with lupus, but it's not directly the direction of the relationship is not always as concrete as some of these other autoimmune diseases. IBD, inflammatory bowel disease, is also another autoimmune disease that's associated with kind of metabolic disruptions, but not necessarily strictly obesity. But what I want to focus on is the mechanistic link of obesity with inflammation and developing these diseases. So this is a schematic I pulled from a really nice review in a journal called Autoimmunity Reviews. And we're going to be talking about these concepts later, but just to highlight that changes in adipose tissue do have systemic effects on many different tissues, leading to these changes in odds ratios and severity of these different autoimmune diseases. So first, I'm going to be talking about arthritis. So there's two different forms of arthritis that are both influenced by obesity. So psoriatic arthritis and rheumatoid arthritis are both inflammatory forms of arthritis. Joints become inflamed, leading to joint destruction and bone erosion. Essentially, activated autoimmune T cells help drive other immune cells, both innate and adaptive immune cells, to attack the joint compartments. And you may have heard of some of these cytokines being involved, such as TNF, which is tumor necrosis factor, and IL-6. They're more involved in rheumatoid arthritis, whereas IL-17 and IL-23 are more involved in psoriatic arthritis. However, there are overlapping clinical symptoms. These cytokines can activate fibroblasts to secrete matrix degrading enzymes that degrade cartilage. And there are currently anti-TNF, IL-23, and IL-17 treatments available, but as you know, a lot of patients don't reach remission, and we don't know why. We don't know what else they need. And so one piece of that may be related to obesity for some of these patients. So there's a role of obesity in arthritis severity. As Dr. Jonsson was mentioning, obesity is a major risk factor for arthritis, and it definitely plays a role in the load-bearing joints, but even in the non-load-bearing joints, arthritis is worse in finger joints in people with obesity. So that kind of pointed us to the fact that there's likely a systemic role for obesity that's not just directly related to the weight-bearing issues on joints. No therapeutics exist to reduce arthritis in obese patients, except probably GLP-1s, but we'll talk about that at the end. And we do see that obese rheumatoid arthritis patients show worsened synovitis at disease onset and attain lower rates of remission compared to non-obese patients. And this is just an immunostain on the right here for T cells, showing that in low BMI patients, there's fewer immune cell aggregates and infiltration into the synovial tissue, which is the tissue of the joint, compared to high BMI patients, just as one example of one of these measures. Okay, so how does obesity impact arthritis or some of these other autoimmune diseases? I'm going to be talking about arthritis a lot, but these concepts seem to be similar in other autoimmune diseases from what we can tell. Adipose tissue, excuse me, getting over a cough. Adipose tissue is increasingly recognized as an immune organ. So if we look at lean adipose tissue here, it's not totally inert. It's not just a bag full of adipocytes. There's also these kind of resting immune cells, such as T regulatory cells, which help control and restrain inflammation. However, during weight gain and in obesity, the adipocytes hypertrophy because they're so full of fatty acids, and eventually they rupture. And this drives inflammation locally in the adipose tissue. It attracts inflammatory immune cells that shouldn't be there, like CD8 T cells and CD4 T cells. And these further recruit other cells, such as macrophages, into the adipose tissue. And then what happens is the visceral adipose tissue releases systemic mediators, including inflammatory cytokines. So you may have heard of leptin, resistin, visfatin. Resistin will increase of inflammatory cytokines, including IL-6 and IL-1 beta. Um, and I just have a little call out here on leptin. As you may have heard of leptin before, there's so much literature about leptin specifically as an inflammatory adipokine. As you can see, it has some direct effects on various tissues, but it also has a myriad of effects on the innate and adaptive immune systems, including increased polarization of T cells to a state called Th1 or Th17. These are often T cells associated with autoimmune diseases. So we really see that obesity leads to systemic activation of immune cells. And this not only impacts joint inflammation, but inflammation in other tissues. Other links between obesity and inflammation that are worth mentioning, as Dr. Jonsson mentioned, obesity strongly leads to type 2 diabetes and insulin resistance. And insulin resistance itself can also impact immune cell function. It can increase macrophage secretion of IL-6 and TNF and T cell function. So that is another kind of result from obesity. A high-fat diet, quote, Western diet, can also increase the permeability of the intestinal barrier. This can alter the composition of microbes in the gut and increased entry of LPS-bearing bacteria, which also lead to systemic inflammation. And one other thing worth mentioning about the high-fat diet is that recent work from our lab shows that this increases type 1 interferon levels. Type 1 interferon has been shown by other people to kill T regulatory cells, which I mentioned before. There's many T regulatory cells in lean adipose tissue. Their population decreases drastically in obese adipose tissue. And this type 1 interferon signaling in T cells, in CD4 and CD8 T cells, actually drives these pathogenic T cells and increases disease severity in arthritis, which we've shown, but another group separately has shown that this same mechanism happens in EAE, which is a mouse model of multiple sclerosis. So there's evidence that there are likely conserved pathways that are happening in multiple autoimmune diseases that obesity is really driving. And I'll just mention this slide very briefly, as Dr. Jonsson showed a similar study just showing that weight loss alone can have an impact on arthritis severity. In this study, people were given bariatric surgery, and on the graph on the left, we're looking at BMI, with which Dr. Jonsson helpfully defined earlier. And after the bariatric surgery, these patients lost significant amounts of weight. And then if we look at the graph on the right, looking at the rheumatoid arthritis disease activity, basically people who had high, moderate, or low disease activity all showed remarkable decreases in disease activity after their bariatric surgery and weight loss, with much higher rates of remission attained as compared to the baseline, which is pretty remarkable. Other considerations besides, purely losing weight would be taking prebiotic supplements to try and help reverse negative effects of high-fat diet. Of course, adopting a lower fat diet can help reduce the systemic inflammation, even if there's not a huge weight loss. Low impact exercise can help patients lose weight without, irritating joints. And I see there's okay. So my last slide, and I'll just talk about this briefly, is Dr. Jonsson already had a very nice explanation of GLP-1 agonist. Um, naturally, GLP-1 is released after eating, and these GLP-1 agonists mimic the GLP-1 to help aid in weight loss, as we talked about earlier. And there is mounting evidence that GLP-1 agonists reduce the severity of rheumatoid arthritis, as well as other autoimmune diseases, um, including psoriasis and lupus, which is very exciting. And I think there's going to be a lot more literature in the coming years about the exact mechanisms governing this, besides just the weight loss, what the impact on immune cell populations are, and so on.
Thank you so much, Dr. Faust. I love the way you brought the research to life for us. And I know there are going to be a lot of questions. We've heard the patient experience. We've heard a bit about what it's like on the clinical side. We now understand the research a little bit better. So please do put your questions in that Q&A. We're going to get that started in just a moment. Just before we do, I'd love to do another poll just to hear, what are you most curious about? Is it about whether GLP-1s could be right for you? Are you wondering how to talk to your doctor about your weight and inflammation, what the research means for your condition specifically, what kind of lifestyle changes you can make? What are you curious about? What would you love to have answered in this session? This will also help us understand what else we can bring you in terms of support and resources. And it looks like we've got kind of across the board a few things. I'm going to share this with you. We're seeing a lot about GLP-1s, of course, how to bring up this conversation with your doctor, which I think Staci could definitely help us with, and so could Dr. Jonsson. That latest research, if you have those questions, please do put those in the Q&A. Okay, we're going to move into our Q&A session now. I will have all of our panelists join us and we can put down the presentation and start some of these questions. So the first question I have here is, are there any common side effects that rheumatology patients on GLP-1s should be aware of? Dr. Jonsson, maybe this is a good one to start with you.
Yeah, happy to start with that. I think the good news is that there's not anything immediate that you need to worry about. I haven't heard of anyone feeling like their joints are flaring after starting a GLP-1 or anything like that. I think as a rheumatologist, and also, like I would say that for anyone who is a rheumatology patient, like I think this is something that we're going to be keeping our eyes on. These medications are new, and so we don't fully yet understand the long-term effects. The one uh little tiny, like tiny little red flag that I've seen is that there might be an increased risk of osteoporosis or low bone density with prolonged use of GLP-1 inhibitors, or agonists rather. And so, for people who've taken a lot of prednisone in their lives and might already have some trouble with low bone density, is that going to get worse on a GLP-1 agonist? The good news is that that's something that your rheumatologist can monitor with you. So, there are medications for osteoporosis. You can monitor with DEXA scans and so forth. And so I don't think that that alone should scare anyone away from, especially from having the conversation with their primary care doctor, with their rheumatologist about these medications.
That's a great point. Staci, what was your experience with that getting on a GLP-1? Did your doctor let you know about anything to look out for, and how have you been feeling so far?
I've been doing actually pretty well, thankfully. I was prepared for a little bit of nausea, upset stomach, all of that. And I will say the one thing that I've had a little waves of nausea, but some of it kind of comes with my app just not being full all day too. It's kind of like you eat a little too much and you're like, okay, I feel bloated almost right now.
Mm,
But it hasn't been too bad. The other thing is a little bit of acid reflux. So it's
mm.
nothing that's not manageable. I was very nervous about it going into it, and it has been very manageable actually. I also was given by my doctor some nausea medication just for safety's sake, which is nice to just have on hand. So yeah, it hasn't been too bad.
Yeah. Heather, as I'm thinking about this, as we kind of look ahead and these therapies continue to be refined and they look at what's coming next, as we look kind of down the line. Do you think some of these things will improve over time in the therapies that come out? Do you have any sense of what that will look like?
Yeah, that's a great question. I have heard of, some of the side effects, and I think, it'll be interesting to see what the longer term side effects are of some of these drugs since they're still, relatively speaking, very new. Um, I'm sure there will be some improvements to them in the future.
Mm.
I'm not I'm not sure what they would be. I don't know if Helena's thought about this at all, but it'd be great if there could be maybe modifications to kind of help
Mm.
reduce some of the unwanted side effects.
Yeah.
Yeah, it seems like in these clinical trials too, they look for ways to mitigate that and what that might look like. Did you have anything else to add, Dr. Johnson?
Yeah, I mean, I think that there's been a lot of development in terms of dosing. I think that initially the doses of these
Mm.
medications were pretty high, and that leads to a lot of weight loss, but can also lead to a lot of side effects. And so I think that people are getting more detailed and refined with, like that different people need different doses, and
Hmm.
maybe slow is the way to go. I think the fact that it now comes as a pill is also great because pills are a lot easier to make, and so hopefully they'll be lower cost in the future. And so some of these sort of logistical and cost hurdles will be overcome. But I think those are sort of the main developments I'm looking for. The other ones are that, like there are many cells in the body that express receptors for these medications, and so I think we need to
Hmm.
understand better how do these medications directly affect the immune system? Like how are there things that we need to watch out for? Is there an increased risk of infection? Is there a decreased risk of infection? All these things, and that just requires time. And so but I think everyone has their eyes on all of those things, and so those issues will be answered probably within
Right.
2 or 3 years.
Yeah, that actually leads well into the next question we got, which is, could small doses of GLP-1s possibly help inflammation for people with a normal BMI who are living with inflammatory conditions?
I can see why someone would ask that, and that is a very valid thing to wonder about. I do not think that that's going to be a great idea right now because I don't know, and like would love to hear your perspectives on this, Heather, as someone who studies like adipose tissues and cells and things like that more. But I don't think that we know right now of any effects of GLP-1s directly on those tissues that would work if somebody is not, does not have a BMI over 30, let's say.
Mhm.
Yeah, Helena, I agree. Right now, I'm not sure that there would be any great benefit for someone with a quote normal BMI, but the only thing I would wonder is, if there's someone with um, maybe a more sedentary lifestyle that has a normal BMI, but a high amount of abdominal fat, like visceral adipose tissue. I actually didn't talk about this really in the talk, but most of the immune changes that we see in adipose tissue that I was talking about that are really inflammatory happen in the visceral adipose tissue, which is in your abdominal cavity. So, potentially someone, I'm not sure what the scans are, but maybe if you find you have a really higher amount of visceral adipose tissue compared to your BMI, then potentially, although I'm not sure doctors are allowed to prescribe for, based on those guidelines yet or anything, but that may be one area that could be looked into in the future.
I mean, I think that right now a lot of people are getting prescriptions, but it's not covered by insurance because it's not for, like an FDA approved reason. And so, that's why there's a little bit of wiggle room here. Like interesting to with what Heather just said of the belly fat, like that belly fat is exactly the type of obesity that leads to psoriatic arthritis. So a lot of studies measure waist circumference as a measure of, belly fat as opposed to how some people are a little bit more pear-shaped and they carry more of their fat in their backside and thighs and so forth. And so, not all those fat tissues are the same. And I think that's probably something that we'll like learn more about going forward as well. But it does seem that GLP-1 agonists are good at hitting those fat depots that are the most harmful.
Thank you. As I think our next question is great for a couple folks on this panel, which is what questions should I ask my rheumatologist about weight and inflammation? I think particularly if you're thinking about these kinds of therapies. And I'd love to hear from both you, Dr. Jonsson, as a clinician, and you, Staci, as a patient. What inspired, maybe we'll start there, Staci. What inspired you to ask, and how did that conversation go? What should people be listening for?
Well, I had a little bit different of a situation that also sparked this. I had a major traumatic knee injury that has caused me to be sedentary for the past 2 years.
Mhm.
And I'm at a very high risk of re-tearing my knee now. So that was a huge thing that actually my surgeon suggested for me was dropping the weight is actually going to help reduce the knee injury to happen in the future. But also, it had been something that I had talked about with my primary care practitioner earlier, and she had brought it up, and she and I thankfully have a good relationship. I know for a lot of patients, it's uncomfortable. And I think it actually, when I was moderating one of these previous webinars, I actually think I might have been on with either one of these wonderful doctors, speaking with them, and GLP-1s did come up. And it got me thinking, like, I don't know why rheumatologists don't also have dietitians in their clinical offices, because it's so connected. And I wish I was given those tools. It's really hard to get in to see a weight specialist. But just I had a good relationship with my doctor, and I'm dealing with a lot of comorbidities that come along with rheumatoid arthritis. And so she just suggested it might be something that I look into. My insurance doesn't cover it, so we're having to go kind of without my insurance company, which is a huge block, I know, for a lot of people, that their insurance won't cover it. So yeah, it's a hard conversation, but it's a really good one to start with your doctor and just kind of dive in and ask and find out what you're scared of, why aren't you moving forward, and if it's the right fit for you, because it may not be for everyone.
Mhm.
That's a great answer.
Yeah, I think those are great points. I think one thing to remember is that your rheumatologist cannot prescribe any GLP-1 agonist for any kind of rheumatologic disease because it is not FDA approved for that. Like there's just that one little clinical trial. And so, somebody just last week asked, like, can you take over my GLP-1 agonist? Will my insurance cover it if you prescribe it? And the answer right now is no. And so this is a conversation. If you're curious about GLP-1 agonists, talk to your primary care doctor. I think primary care doctors probably used to be a little like cautious about this, but I think now they're very widely used. And so your primary care doctor is probably already prescribing this to dozens and dozens of people and will be able to answer your questions um, and uh, and talk you through it. And I think seeing a dietitian is a great idea, whether or not you want to start a GLP-1 agonist. To talk about other diet strategies. They can give you diet strategies for if you are taking a GLP-1 agonist. Certain foods are less likely to cause nausea than others, etc. And I wish we had dietitians in rheumatology clinic as well. Unfortunately, it's a cost thing. And so usually we have to rely on primary care offices or, like referrals to dietitians in other ways.
One that kind of is a follow-on in this. Speaking of side effects, things like that. Someone asked, should someone with arthritis and diabetes talk to their doctor about the effects on their liver or pancreas? Is that an important conversation to be having?
I think that your arthritis should not stop you from taking a GLP-1 agonist if it makes sense for you in other ways. And
Mhm.
so if you have, so talk to your primary care. If you have diabetes and you have an endocrinologist who takes care of your diabetes, then talk to that person and they'll be able to answer those questions about, how this fits for you.
Okay, great. I think we'll probably head into our last question here, which is how can patients and advocates contribute to your research efforts in this area? How can they be part of what's happening next?
Um, I would say, donating to ANRF is great. They
I
funded a lot of
agree.
very nice arthritis research in the recent years, and other arthritis foundations. There's, uh, I assume there's obesity and other autoimmune related foundations as well, um, that can be donated to. Is really the first thing that comes to mind.
Yeah, where would you say people can find, and this is a question for all of you, really based on your experience, where can people find the latest information on this? Is it useful to, are there places to look specifically or ask your rheumatologist? What would you suggest?
I would suggest ask Helena Jonsson.
Um, I think it's probably a good thing to touch base with your rheumatologist about this maybe once a year or so, because this is a very fast-moving field. And because GLP-1 agonists are so popular, there's a lot of great information online, and there's a lot of like really terrible information online. I
Right.
have been impressed with the websites that the ANRF and other arthritis foundations have put up about obesity and autoimmune disease, and even some about GLP-1s. I think that's going to be growing, but again, I think be cautious if you're just sort of like Googling your way around. A better way is to talk to your rheumatologist.
Yeah.
It's probably going to take another year or two before these medications really um, start to play even a small, like real role, like real direct role in rheumatology clinic. And then the other thing is, don't forget to mention to your rheumatologist if you're taking these medications. A lot of people are getting these through like med spas and, directly from the pharmaceutical company and stuff like that. So it might not show up on your medication list, like at your rheumatology clinic. And so make sure to mention it to them. Maybe send them a message today, like, can I make sure that my GLP-1 agonist, whichever one you're taking is on your med list so that they can sort of take that into account. I don't know of a lot of medication interactions, so you don't have to worry about that. But just so that your rheumatologist has an idea about like the different things that are going on with your body.
Yeah. Thank you so, so much. Thank you all for your answers to these questions. Thank all of you out there for asking these questions. We are so grateful for your time and for your expertise. We just appreciate it so much. Before we wrap up for the day, I would love to find out one more time about this question. How confident do you feel talking to your doctor after we've learned so much today? Are you feeling more confident about going in and having these conversations? I know these are big ones that we're all curious about, and I'm so grateful to our panelists for giving us so much to think about as we head into those conversations, for really equipping us with what to ask. Really appreciate that. And I will share these with you now. We are feeling generally much more confident about what to ask in these situations, and I hope that you know more about what these medications do, what the effect is of weight on your arthritis and autoimmune disease, and just for your knowledge, we have lots more coming on that topic from ANRF. Again, I want to say a huge heartfelt thank you to our panelists. Staci, I want to thank you for your openness, for sharing your story with us so generously. Dr. Jonsson and Dr. Faust, we are so proud to call you ANRF scholars, and today's a perfect example of why. A few things before we let you go. We just want to thank our sponsors at Lilly again. Their support really makes this possible, programming like this possible. This webinar is going to be available on demand on the ANRF website coming up very soon, so you can rewatch it or share it with somebody who might have missed this. Tomorrow, May 15th, is ANRF's Day of Giving, and every gift tomorrow will be matched dollar for dollar. So if you're feeling so inspired, we hope you'll make a gift to the organization. You can scan that QR code right there. Your support also helps make this possible, and this year we have a really special giving opportunity that you can make in honor of someone in your village, somebody who supports you. When you make that gift, they will get a video from Staci, who is here with us today. So thank you, Staci, and thank you all for being a part of that. This is just the beginning of Arthritis and Lupus Awareness Month. We have lots more content coming this month. We have 2 more webinars. One is around Sjogren's, see beyond dryness. That'll be next week on Thursday. And then the following week, you can join us for the bigger picture around CAR T therapy. Another big question folks have about new therapies that are in this space. We hope you'll join us for those. All those details can be found on the ANRF website. You can scan that QR code and see our full month of programming. We hope you will join us for as much of this as you can. We're so grateful to have you as a part of this community, and thank you for being here today. Please do follow us on social media to stay connected, and we'll see you next time. Thanks for being here.